We have a male patient, unconscious, breathing spontaneously but in impending respiratory failure. We need to secure his airway but will not be able to intubate using the oral route as his gag is intact and his teeth are clamped. We're currently assessing his ventilations via BVM, and we have a nasopharyngeal airways in place on both nares. He's been optimally prepared for intubation with good oxygenation and good end-tidal capnography. Because we do not have approval to conduct an RSI procedure, we're going to perform a nasal intubation. Because blind nasal intubations have a poor success rate, we're going to use a flexible endoscope to ensure visualization of the glottis during the procedure. The plan is to insert the endoscope through the MPA on one side of the nose and insert the E2 tube through the other side. We continue bagging the patient while preparing our equipment. Then we insert a nasal cannula at 15 liters per minute in the patient's mouth to assure adequate oxygenation during the procedure. Remember, the patient is breathing on his own still. We remove the MPA on one side of the nose and we replace it with an endotracheal tube with a similar outer diameter. We've ensured that the distal cuff is fully deflated and the tube is well lubricated. In this case, we're using a 6.5 ET tube. A bougie is then placed inside the endotracheal tube to just about the end of it. The endoscope is introduced into the NPA on the other side and advanced to just past the end of the NPA. At this time, visualization of the glottis and vocal cords should be enabled. Manipulation of the head and external manipulation of the trachea may improve the view if needed. Once the glottic opening is in view, the bougie is advanced through the endotracheal tube. Very quickly, the distal end of the bougie should come into view. The bougie may be manipulated slightly to facilitate passage through the glottis. Once the bougie has clearly passed into the trachea, the endotracheal tube should be advanced along the bougie. Once passage of the distal cuff through the vocal cords is observed, the cuff is inflated, the bougie is removed, ventilations begin again, placement is confirmed, the endoscope is removed, and the tube is secured.